we know his credentials, and I'm not going to waste time on that. So let's hear from him on the role of biomarkers in follow-up and prognostication of bladder cancer. Over to you, Badri. Thank you.
Thank you very much. First of all, I'd like to thank Dr. Raghunath and Dr. Rawal and all the other organizers who I have not yet completely met for the opportunity to come and present. I know my mother also thanks you all because this gives me an opportunity to go say hi to her and make sure she's doing okay post-COVID as well. So thank you again for this opportunity. I thought I'll take this chance to talk a little bit about different types of biomarkers. We'll talk about biomarkers a little bit in non-muscle invasive and also in muscle invasive bladder cancer and how they can help in prognostication. They told me I had to put a bio slide, so I put it up there. So, and I just wanted to make sure that my conflicts were also disclosed with the different companies that I work with. So the reason for having biomarkers, particularly urine-based biomarkers, where most of the work has been done over the last several years, is because we need something that's consistent, black and white in results, helps us with cystoscopy during follow-up and also during workup. It can help arbitrate atypicals. We get an atypical cytology reading. What do we do with that? Can we help assess who is going to respond to intravesical therapy, such as BCG? Can we triage hematuria patients so we don't have to work up everybody? And then can we really reduce cystoscopy and surveillance? This is the toughest one because as urologists, we always rely on looking in the bladder and doing cystoscopy, but maybe there is a way to do this, like use a bladder PSA, if you will, and avoid doing interventions all the time. The problem with cytology, which has been around since 1945, is it's very variable depending on who's reading it. With all due apologies to our pathology colleagues, it has got very low sensitivity, and you have to send it out, and you have a range of results. You can get atypical, you can get positive, you can get negative, so sometimes it's not clear. There have been some interesting studies done to show that markers can actually help. This is one randomized single-blind trial that was done in the Netherlands, which showed that in one group, they actually did the marker study and told the urologist what the result was, and then he did the cystoscopy. And the other group, they just did routine surveillance cystoscopy at predetermined intervals. And what they found was more tumors were detected when you did the marker right before the cystoscopy, probably because the urologist knows there's a positive test, so we should really be able to find something in there. So there is some benefit to doing markers, particularly at the time of the cystoscopy, if you're able to get the result to the urologist. Overall, over the last 30 to 40 years, I've been involved in marker studies at least for 20 plus years, and a whole host of markers have come about, and continuously there's progress almost on a monthly basis, a new markers being released. There are protein-based markers, DNA-based markers, RNA-based markers, tissue-based markers, and then now companion diagnostics and multi-gene arrays have also come. We won't go into all of this in the interest of time, but at least I'll talk about the top 4 or 5 categories of markers briefly. This is just a historical note. Many of you know data on NMP22, BTA, and immunocyte. These are historical relevance only. These markers are all FDA approved, but almost nobody uses this anymore. The only value we found in these markers is they were able to come up with a pregnancy test type format for the protein-based markers NMP22 and BTA. That's really helpful to do right before a cystoscopy or even in the absence of cystoscopy. But the marker characteristics are so bad, we cannot really use them anymore. I don't even think you can buy them now. At least immunocyte is completely out of business. This is a newer protein-based marker that has really caught some attention over the last few years. It measures a protein that's important for DNA replication, which is lost as cells get more differentiated. So in cancer cells, there's a lot of MCM5 that can be detected. There's 3 large studies so far, and the marker is very good at identifying muscle-invasive disease, all the way from T2 to T4. It's also very good at identifying CIS, but it's a coin toss for identifying PTA disease. So it really has potentially some value because of its high negative predictive value. If you do this test in the urine and the test is negative, then the patient is unlikely to have aggressive disease. So there is some attractiveness to this marker. FISH is a DNA-based marker. This has been around for a long time, very popular in the United States. About 25% of all bladder cancer patients undergoing surveillance get a marker test, and most of them get a FISH test. And it identifies increased copy numbers of genes, and you see the read as shown in the picture on the right. It looks for 4 markers: loss of 9p21, which is the most common and first occurrence in bladder cancer. When it goes from papilloma to cancer, the first thing that happens is you have 9p21 loss, and then you have more than 2 copies of chromosomes 3, 7, and 17. So it's a good test. Again, it has to be done by a pathologist, and really it actually pays about 3 times as much as cystoscopy in the US. So urologists love this test. You can do the cystoscopy and do a FISH and make quite a bit of money. You can make more money doing these 2 tests than doing a radical prostatectomy. So it's very popular. These are the DNA-based markers that are newer, again, very helpful, good performance characteristics. Bladder EpiCheck is by a company in Israel that has got very good test characteristics. Assure MDX is also a very good test, but it's very expensive. And it's not yet available in the US, so we don't have a lot of experience using this. It tests for DNA methylation and some gene mutations. The problem with these methylation profiling tests is they look at a whole bunch of different genes. It's unclear exactly which are important, which are not. All the studies are very small, so we need larger studies, and most of them have just focused on ruling out patients with hematuria. So you do the test, and if it's negative, you don't need to do cystoscopy sort of thing. Euromonitor is, again, a nice, interesting test that has come out. Very small, 2 very small studies, but really remarkable performance characteristics. Looks for 3 specific gene mutations: TERT, FGFR, and KRAS, all very common in bladder cancer. FGFR3 mutation is probably also one of the first mutations to occur in bladder cancer, so it's very popular. We even have drugs now targeting FGFR mutation, so it has some value. And it's very common. FGFR change is very common in low-grade tumors. Again, this test looks too good to be true. We need to get more data. As you can see, the number of patients it's being tested on is very small. Again, this is just a laundry list of all the DNA-based markers. I won't go through all of them, but you can see there's just a lot of activity in this area. Lots of companies that are investing and coming up with different things. Then there are RNA-based markers. The advantage of RNA-based markers is these are markers, genes that are actually being expressed, so they probably really mean something. The problem with RNA-based markers is the RNA degrades very quickly, so it's very technically difficult to do RNA-based tests as opposed to DNA-based tests. I've got a lot of experience using CX Bladder, and Expert Bladder Cancer is the other RNA-based marker that are available. They use different genes that they're analyzing for. Very good performance characteristics. And CX Bladder is made by a company out of New Zealand. It not only uses the gene mutation test, but also looks for, adds other variables such as patient's bladder cancer history, age, gender, etc., and comes up with a score. And there's a cutoff which tells you if this patient has bladder cancer or not. They also have another version that tells you if the patient has high-grade bladder cancer or not. So it's very good for 2 different things: to evaluate hematuria, but to also determine if somebody who you're doing surveillance on has high-risk or high-grade bladder cancer. It performs better than most of the other studies the other tests that are out there that are FDA approved, NMP22, as well as Eurovision FISH. We've used it in adjudicating atypical cytology. So if you get a patient with atypical cytology and you do a CX bladder and the CX bladder is negative, there's a 0% chance that the patient has bladder cancer. So you can avoid unnecessary upper tract studies, cystoscopy, biopsy, all of these things. So it's very helpful for us in that regard. Expert Bladder Monitor uses a whole bunch of 5 different genes. And again, it's a very useful test, but the performance characteristics are not that great. Just a good backstory to this test. The reason this test was developed because the owner of this company, his mother developed bladder cancer and died from it. So he felt so sad. He said, I'm going to develop a test to identify bladder cancer early. And so that's what led to the formation of this test. It's still not being very commonly used because we're still waiting to find out if we can improve on the performance characteristics of this test. We did a meta-analysis a few years ago, and we found Assure MDX and then CX Bladder to be the 2 best tests compared to all the others available at that time, both in sensitivity and specificity. This is a more recent study from the last year from a European group that looked at 5 different markers: ADX, CX Bladder, EpiCheck, Euromonitor, and Expert. And what they found was all of the newer tests had better sensitivity than cytology, had less specificity than cytology, had better negative predictive value than cytology, and lower positive predictive value than cytology. So there is some value to these new tests, particularly because of the high negative predictive value. So if the tests are negative, you don't need to pursue a workup. And many of the tests can also help identify high-grade tumors or high-risk tumors. So I think there's some value, but we have to see truly how we can apply that. And so there's the first randomized clinical trial that we're part of using markers to see how you can change management of bladder cancer. That's ongoing. So once the study is done, we'll get more data. But if you were to use markers to change how much cystoscopy you do, you can actually use some of these markers to reduce the number of cystoscopies without sacrificing detection of recurrent tumors. So the best two tests at this point look to be CX bladder and Euromonitor, which you can reduce the most number of cystoscopies by missing the fewest number of tumors. So in conclusion, these markers allow more accurate detection of low-grade tumors. They have about a 30% false positive rate. You can help resolve atypical cytology. They can be an early indicator of BCG response. I didn't go into the data, but we and others have published data showing that it can early detect whether somebody's responding to BCG or not, and then you can stop BCG if if the patient doesn't seem to be responding. You can reduce the surveillance cysto frequency in some patients, more efficient workup of hematuria, but we still need to better define utility and costs of these markers. The AUA guidelines for microhematuria say you don't need to use any marker, including cytology. They don't endorse use of any of the markers for surveillance or as part of the testing in the workup. But they do endorse use of these markers in arbitrating atypical cytology or equivocal cytology, and also to assess BCG response. A quick word on tissue markers for muscle-invasive bladder cancer. Several groups have analyzed the DNA and RNA mutations and gene expression in bladder cancer tissue derived from radical cystectomy, the UNC group, MD Anderson group, TCGA, which was the national effort, and Lund group in Sweden, as well as one of the companies called Genome DX. And all of them have basically tried to separate out bladder cancer, muscle-invasive bladder cancer, into more luminal-like or into more basal-like, basically arising from the basal cells or from the luminal cells. Luminal tumors in general have a much better prognosis. They're papillary. The cure rate is much higher for these tumors. And one of the thoughts was whether P53 expression could tell us who is going to respond to chemotherapy and who is not. Early studies suggested that maybe there was a difference in response and survival based on P53 expression. A randomized clinical trial was conducted, and P53 was used as a correlative marker, and it did not pan out. So just using P53 does not seem to help us. But if we use the overall gene expression profile, you can actually separate out tumors, muscle-invasive bladder cancers at cystectomy, into different groups. And you can also identify who may respond to neoadjuvant chemotherapy and who won't. And in this one study, it demonstrated that basal-like tumors had the best response to neoadjuvant chemotherapy and got the most benefit in terms of survival. So basal tumors that got neoadjuvant chemotherapy would almost behave like luminal tumors, whereas the other two subtypes of muscle-invasive bladder cancer, there was no benefit of giving them chemotherapy. There is some evidence that luminal infiltrative subtype of muscle-invasive bladder cancer may respond to immunotherapy. So using this type of tissue-based analysis may help us determine who we should give chemotherapy to before cystectomy, who we need to give maybe immunotherapy to before cystectomy. There's some good data now suggesting that's helpful. And we have a trial that we conducted which showed combination of chemoimmunotherapy before cystectomy may be even more powerful. So it looks like you cannot really tell who is going to, which of these analyses is the best one just yet. We still need some more data to confirm whether we can use some of this marker profiling to determine how to treat these patients. But I think there's potentially a lot of progress forthcoming that'll help us. Thank you again. Sorry for going over.
Thank you very much, Badri. We know of your interest in bladder cancer, and we look forward to hearing you again in the plenary session. So I think since we are sort of beating the clock here, you want to...
Yeah, as a medical oncologist, in the metastatic setting, FGFR is now a standard. Whenever we check in the second line, we do FGFR, and accordingly, if at this point of time it is not available in India, the drug, but now it is more or less a standard. So I think slowly we are going towards the molecular classification, like in other organs like stomach and lung and breast, so that we can fine-tune and reduce the toxicity. So any consensus as of now, are we going really towards the molecular classification, or still we are few years behind?
For muscle-invasive bladder cancer, I think we are. I mean, I use it on every one of my patients before we do cystectomy. And I think some of the people who do a lot of bladder cancer in the U.S. are routinely, we're all doing the same, part of the same studies. And most of us are using Decipher, but there are also several other groups. Sloan Kettering has its own set of markers. That is a challenge. Everybody has their own customized marker set. So which one to use is...
so for all patients who are going for neoadjuvant chemotherapy, you are doing this panel?
Yep. What we will do is if somebody has got other reasons that they may not be